All right, so that'll start recording for us. All right, so for the class, you can see just about everybody. There's a few more people sort of out of your range there. But we have David, we have like 12 to 13 students in here, a mix of masters and PhD students, and also a mix of backgrounds in and what we would each define as performance. So we have some nutrition, clinical nutrition, some sports nutrition, some exercise physiology. So that's sort of the class that we've got here. At this point in time, we've made it through the basics of cell signaling and receptor interaction. So that's our level of depth at the moment. So keep that in mind as you're going through your talk to what the class has had exposure to so far. And just for the class, like if you've taken my other classes where we have a lot of speakers, you're familiar with this. But if you're not, I try to bring in like the best people to get you guys connected to like current work in this field, and also to create networking opportunities. Because if you ever see Dr. LeMay around at a meeting, now you have something to talk about. You can say, hello, I met you somewhere. We met. Dr. LeMay was working with Exos. I think we were both working with Exos in some capacity like 6 years ago. And we had an on-campus meeting here that was of one-day seminar. We brought speakers into a big meeting hall across campus, and it was wonderful. And Dr. LeMay was highly recommended to me to invite through the Exos contacts that we had. So that's how we met. He also lives not too far west of us. And do your daughters still play volleyball over here?
You know, she's out in Los Angeles in school, so she's not playing anymore.
Okay, so she used to be here playing, doing some of the camps and such, so we'd connect every so often. But I love to have Dr. LeMay come and speak about this stuff because it's really the only practitioner, like a medical doctor, who works in this area specifically, and it's known. I'll let him intro. I'm not sure your latest and greatest connections with pro sports and military. Maybe you can walk us through that a little bit. But we're real interested in what you've got to offer us because we're kind of stuck in a textbook, and we want to get out and see what's really happening with some of your athletes and your special ops guys and all the neat things you're working on. So I'll let you take it from here. We've got exactly 1 hour until another class comes in. So maybe we can go about 45 minutes and then take some questions from the group. Does that sound good?
Yep. Sounds good.
Thank you very much. We'll let you get going.
Yeah. So this lecture that I'm doing is actually something that I gave at the SOCOM Performance Nutrition Summit, which was last year. And I do this a lot. I'm in the human performance department as a consultant for Naval Special Warfare. I do a lot with SOCOM and an organization called IHMC, which is in Pensacola. And then also they have a branch down in Tampa. So they do a lot of research with DARPA and NASA. My background is in physical medicine. And I was a brain injury director for a rehab unit for about 4 or 5 years. So I was always interested a little bit in the neuroendocrine stuff because I really felt like part of what we did in trying to rehabilitate people was, just kind of, we were missing something. There's nothing medication wise you can do to help people. You could do a few things, amantadine to wake them up, which actually raises a neurochemical called dopamine. But there really wasn't much, and we would find these neuroendocrine problems sometimes if you tested, but who knew what to do with them? And we'd kind of send them over to endocrinology, and they'd say, yep, they've got a problem. And then they'd send them back. And we'd go, okay, what do we do? I don't know, they're too young to treat. Why are they too young to treat? They have the problem. So, that was kind of the point for me where I kind of, looked at it and said, okay, my goal is to maximize performance, not to just wait until somebody is sort of the politically correct age of treatment. My goal is totally different than say what somebody would be doing to treat diabetes. So that was kind of a beginning for me. But I started working with the special operations community about 10 years ago through in part through Exos and Andrews Institute, where I was working. And then that's kind of branched from there because of some of the contacts. And this is where, Dr. Ormsby was talking to you about networking and contacts. It's really how everything runs in the sports world. So I got pulled in with the Wizards Wizards, the same ownership as the Capitals. So I got pushed over to the Capitals and the Wizards, worked a little bit with the Mystics because I'm up in DC, did a little work with the Nats. The strength conditioning coach at the Wizards left and went with the Cardinals, so pulled me over to the Cardinals. The head trainer left and went to the Jazz, so I started working with the Jazz. One of the physical therapists at Axos took a job at Oklahoma City with the Thunder, so I started working with them. The Cardinals referred me over to the Toronto Blue Jays. The Toronto Blue Jays head trainer went to Atlanta, and so I've done some work with the Braves. So it's the networking is just who you know. It's not a website, it's not a poster that you put up somewhere. It's just people that you know, and people that you know kind of get to know you and go, man, this person has some knowledge or information that I think can help, and they're easy to work with, and I want to pull them in. So that's kind of how things have spread for me in the pro sports world. And so kind of in beginning of the discussion of this in mindset or how to think, one of the things that you guys will probably find if you're in the sports world or even just in clinical nutrition is that your mindset will be different than the traditional medicine mindset. And not that we in medicine are, bad people or we do everything wrong. It's just our sort of traditional training doesn't step in until somebody is sort of at a dysfunctional state. And in fact, one of the conversations that I had with a friend of mine who's the nutritionist or does some consulting at least over at with the Golden State Warriors, and now they have a different nutritionist, and so we still work with some of the players, but it's kind of interesting environment. They have a new doc there, and the doc is like, why are you doing nutrition testing? This person doesn't have any complaints. Okay, I understand, but we're trying to prevent things from going wrong rather than waiting until somebody has an Achilles tendon rupture and then saying, now what do we do? So the mindset, there's a spectrum that happens of thinking in health. And what our goal is in, the professional sports world or collegiate sports world, or even in, if you're dealing with clinical nutrition, is how do you optimize somebody? So if I have somebody, for example, who maybe does have some dysfunction. Maybe I'm treating somebody that had a concussion or a brain injury, so they're dysfunctional, but I still want to push them towards optimal. I want that person to be as highly functional as I can get them. So the things that are part of that discussion obviously are nutrition, the environment that person is in, which can be home environment, it can be stressors that they have at work. It can be, things that they're around in the military community. It can be things like electromagnetic radiation and lead exposure and plastics and some of the things that they get treatment for as prophylaxis. They, put them on a medication to prevent malaria when they go overseas, but that drug is toxic to mitochondria, to the nuclear power plants in the cell. So all of these things play a role, and the environment, your nutrition, stress mitigation, these are things that play a role in what's possible from an optimization standpoint, and that's filtered through your genetics. And genetics you can't control, but it's a loaded gun. So if I have a loaded gun, it's everything else around it that pulls the trigger and decides, okay, what am I going to do with my genes? But most people operate in a suboptimal range. I mean, and this is true for baseball players and basketball players and just about everybody that I see in the sports world or military world. They say, I feel fine. Well, some of them don't. Some of them don't feel great, but they might say, I feel fine. Why do I need to, work on my sleep? Or why do I want to go out and party every night and come in at 2 a.m. and then come into practice? I'm good enough. I can do that. I did that in college. So why start doing something better now? But it's the breakdown over time that's the issue. And most people exist in the suboptimal range. And so because of diet and stress and other issues, they end up with micronutrient deficiencies. Maybe they're not getting enough protein, so macronutrient ratios aren't appropriate for what their level of activity is. And they start to have these compensated states. And this is true with, for example, this is true with let's say a pitcher that's having a little discomfort in the front of their shoulder. Does it mean that they have only a shoulder problem, or is it possible that the hip flexors are really tight? And so when they're doing, their wind up or cocking phase, maybe they are putting extra strain on the shoulder, and the problem is not at the shoulder, it's a secondary issue. So all of these things play into how you should approach your patient population. And then how do you bridge that then into the medical guys? Because you're going to struggle a little bit sometimes with some of the sports docs. Some of them are going to be very open and say, I'm willing to listen to everything that you have to say. And some of them have already made up their mind about everything. And as long as the patient has no complaints, you should not be testing or doing anything. You just wait until something happens. And this is where stress starts to play, I think, a big role. This is one of the issues. We talked about nutrition, we talked about environment, but stress is a huge player in what happens with optimizing people. And without any stress, people die. People retire from their jobs. The average lifespan after retirement is like 7 years. And whether that's because they don't have anything that spurs them, or they're retiring from a medical illness, I don't know if I can really tease that out, but it's an interesting statistic. So if you don't have any stress, you really don't get anywhere. So you need some, but you can stay at sort of that optimal, that peak area only if you're really focusing on controlling the factors around it. And when you get past the point where your body can handle it, then you start to break down. And this is sort of a better curve that kind of shows what's happening. You get to that point where you're comfortable and you can get past that and get a little bit better, but you'll start to have problems with fatigue and exhaustion and getting sick because it changes your immune system and gut health. And eventually it increases your risk for breakdown. Your injury risk begins to go up. And this was something that was, this was studied 50, 60 years ago, when people were starting to look at the hormone responses. And some of the things that they noticed were that if you took cortisol and DHEA, which are both adrenal hormones, cortisol will go up because cortisol is there to make you manufacture fuel. It makes energy available for your body, and it continues to drive adrenaline production so that you can stay in that fight or flight state. And DHEA sort of protects your body from cortisol damaging it, because if you just have cortisol, so if you look at that, that second block there from the left, if your cortisol is up and DHEA begins to fall, cortisol will destroy everything. So cortisol by itself, without anything to oppose it, will start to break down muscle and bone and tendon and ligaments and brain. So it's turning everything it can into fuel, basically. So in a normal state, cortisol and DHEA kind of follow each other, but in a stress state, cortisol and DHEA begin to spread. So that's one of the things that I'll see sometimes on lab, and it's particularly common in the special operations community. You see this ratio is way off, and they're in what we call a catabolic state. They're breaking everything down. So injury rate is much higher. And there's a name for it, which some people argue doesn't exist, but I think it fits very well for the model, which is called overtraining. And you get a decrease in performance, you get fatigue, start to have mood changes because it changes what's happening with chemicals in the brain, a lack of motivation, there's an increased risk of injury, there's sleep disruption that happens, recovery is really slow. So all of those symptoms you'll see in these guys, these high performers that don't really take time off to rest. Under recovery is the other sort of description for it, which is good too. When people are under recovered, they have all of those symptoms. And the performance drop is it's caused by neurochemical shifts. So you get central fatigue, changes in what happens with tryptophan metabolism. We'll talk about that in a minute. Inflammation and oxidative stress levels are significantly ramped up, and the person has a hard time basically controlling that. You get gut permeability issues, which start to develop and increases inflammation. And then you start to have the shifts in hormones. So cortisol and DHEA, and that further shifts over into other hormones like testosterone, which will affect recovery, or estrogen in women. So this is just an old article from a sports medical journal, but what they described is stress. The stress system becomes overactive, the nervous system becomes imbalanced. So there's a change between sympathetic and parasympathetic balance. And this is why things like heart rate variability can be useful in monitoring people when you're training them. Even though a lot of the monitoring devices are not perfect in their, sort of the information that they give you, they're still helpful. You start to have immune dysfunction. So your ability to fight off infections becomes impaired, and then your risk for things like allergies begin to go up. So people start to have more stuffiness and congestion and reactions to the environment and foods and those kind of things. And then they get impaired gut function, which leads to amino acid imbalances and vitamin deficiencies. And every pathway in the body requires these as cofactors. So this has been sort of the argument that I hear sometimes is, you get everything from food, which 100% agree that that's the starting point. You can't supplement your way into a good diet. It's impossible. But anybody that has a stressed lifestyle is going to end up with some sort of nutrient deficiency, and certain genetic predispositions cause people to not absorb things well. You might not absorb iron or B12 or vitamin B2. Something may genetically be an issue for you, and you need extra of that nutrient, and then it's difficult for you to do in a stress state. So that's part of the reason why I think nutritional testing helps so much. And I see good feedback from the people who do it when you can look at them and say, okay, here's how you need to change diet. This is what you're missing, but for now, I'm going to put you on something to kind of supplement and replace this while you're fixing diet and while we're fixing the stress response. So the first thing I kind of want to shift into is what's happening with the brain. So neurochemically, what begins to happen. And that has to do with the deep brain. And we discussed a little bit about the cortisol DHEA changes. I mentioned testosterone or estrogen becoming issues, growth hormone, which is available for repair, or it's necessary for repair of tissues, becomes an issue, and thyroid dysfunction. And thyroid is what controls your metabolism. How much energy can you produce, and how much can you use carbs or fat to produce ATP, basically. Your mitochondrial production is dependent on thyroid function. But sympathetic and parasympathetic function is partly what drives some of this response. And the controls in neurochemical production are significantly impacted by your stress levels. And so I don't know if you can, I don't really have an arrow here, but basically the little area around the pink structure that looks like a...
you can see your cursor if you use your mouse.
Yeah, I can't see it on my screen, so...
Okay, never mind.
Yeah, sorry about that. But if you look at the little, can you see the pink almost looking like a horseshoe structure there?
Yes.
That's a hippocampus. And in the middle of that, so the yellow structure is supposed to be your amygdala, and that's your threat response. And then the gray structure that has a bunch of blocks, looks like Legos put together, should be your hypothalamus. But that's the area in the limbic system that controls threat response and basically decides internally whether you're going to be in a position where you're repairing and rebuilding, which is more parasympathetic function. That's typically more common at, it's more dominant at nighttime, where it should be. Or if you're in sympathetic response, which is more dominant during the day, and that's just pure survival. It's fight or flight. This is kind of self-explanatory. Lots of different causes of stress, so I'm not really going to go into details on that, but I want to point this out on this slide, that there is a significant communication that happens between your brain and these different areas of the brain, the amygdala, hypothalamus, pituitary. You get hormone release, and the hormone release affects immune system function. Immune system function affects what happens with neurochemical production, and all of those things will affect gut function. So it's top down and bottom up, is both directions. Your vagus nerve is one of the largest nerves in your body and controls most of your GI tract. And when you're in a stress state, your vagus nerve function changes. And if you have a TBI or concussion, it changes vagus nerve function and changes bacterial growth in the gut. If you have gut issues, an infection, or you're chronically on antibiotics, it changes what happens with the gut bacteria, and that changes communication with the brain through vagus nerve, and also through what's called the glymphatic system, which is your immune, basically lymphatic communication with the brain, which bypasses what's called the blood-brain barrier. So we used to think of the brain as an encapsulated organ that has no communication from the body and is totally walled off, and that's not true. I mean, over the last year and a half or so, we've kind of figured out that that's the immune system directly communicates through the gut through those mechanisms. I'm going to kind of skip this and get into cortisol a little bit just for the time limit. But when we're talking about what happens with cortisol, cortisol cannot, or your body cannot function or survive without cortisol. Your body dies. It's called Addison's disease. If my DHEA is low, I slowly deteriorate because DHEA helps with inflammation or curbs inflammation and cytokine production. Cytokines are sort of the immune cell's chemical communication. Testosterone levels can fall in an aging male, and I can start to have problems with osteoporosis and muscle loss and blood sugar regulation because of that. But I die without cortisol. Cortisol is like a primer on a round if anybody hunts or shoots. You can have all the powder in the bullet that you want or the right size bullet, but if you don't have a primer, nothing works. And cortisol drives up the production of adrenaline, which helps with glucose regulation. So when cortisol is lost, a lot of the control mechanism is lost, and then people end up dying. The downside to high cortisol in the brain, since we're kind of starting with the central aspects of what's happening, is that cortisol makes everything in the brain shrink. So hippocampus, which is short-term memory, begins to shrink. Your threat response is the only area in the brain that actually grows, which is your amygdala. So you become much more efficient at responding to stress. You'll ramp up cortisol production really quickly, but everything else begins to shrink. So short-term memory issues are common. Visual spatial awareness, or your risk of injury, goes up just because your position sense in space begins to become a problem. It increases your adrenaline. It causes changes in the neurotransmitters in the brain, which we'll talk about in a minute, and increases inflammation. So here's sort of a summarization. What happens with cortisol? You suppress your immune system, you suppress digestion, you suppress reproduction typically. So you're not getting the repair hormones, growth hormone or testosterone, or in women, estrogen. Estrogen is really important for muscle function and recovery in women. Suppression of growth factors is an issue with high glucocorticoids or cortisol. And then you mobilize energy. So you're just destroying tissue if it doesn't have any opposition to anabolic hormone function. So is this so far making sense to people? Like,
yep.
Going too fast?
Yep.
Okay. All right. Stop me at any point if you've got any questions. But just kind of proving the point on what's called the hypothalamic pituitary adrenal axis, or basically, your cortisol and what's happening with your brain. There are studies that are done on this stuff. It's interesting in medicine. What do we do with people who are depressed? Well, we put them on an antidepressant. What does that mean? Well, we stop the breakdown of serotonin with a drug or a medication, but we're not really figuring out why they have the problem. So if they're stressed and cortisol is high, and that's causing the problem with serotonin, which serotonin makes you happy, or dopamine, which gives you motivation and drive. So if something is underlying and causing that, we don't fix it. We just throw them on a medication, and it's like slapping mud on the wall and seeing what's going to stick. But there are tons of studies that are available looking at hormones and how it affects mood. And just kind of a quick note into how, like in the professional sports community, and one of the teams that I work with, we just had a player that had a severe depressive episode that had to have treatment, a basketball player. And when we've done labs with him, his diet is not good. His total cholesterol, I think, was 90. He just doesn't eat much. So if he doesn't have the ability to produce neurosteroids or chemicals in the brain, it's not going to be a surprise when he is depressed. Vitamin D was low, homocysteine is high, which he's not able to manufacture certain neurochemicals. So what do we do to treat him? Well, we'll put him on an antidepressant to kind of get him out of the depressive phase, but it's not enough. Just doing that is not enough. You have to fix their nutrition. And obviously this guy's got some serious nutritional deficits with the total cholesterol of 90. Again, what's he going to manufacture that helps with his mood and cognition as far as steroid production in the brain? We'll talk about that in a few minutes, but it's really common. And looking at cortisol and DHEA ratio, what happens when cortisol is high and DHEA is low? And these are associations that you see: less memory, poor learning, poor sleep, more protein turnover, connective tissue turnover. So you're at a higher risk for injuries and bone turnover, stress fractures, higher risk of stress fractures. Insulin signaling has changed, so you may become insulin resistant, even though your muscles need the glycogen storage. You may have a hard time getting that in, or amino acids into the muscle because of insulin resistance. Pro-inflammatory state and immune system changes. We discussed that briefly. It's harder to get rid of environmental toxic waste. Guys that are exposed to lead in the military community, if they are in this really stressed state, the body's not worried about detoxing, it's worried about surviving. So it's harder to get rid of some of those toxic waste exposures. You get more protein turnover, you gain central body fat over time, serum lipids begin to go up, so cholesterol can go up. We talked about anabolic catabolic shift. You're in a breakdown state, and then poor nutrient absorption and increased absorption of what's called lipopolysaccharides from the gut, which will drive an inflammatory response. So getting into this nutrient deficiencies state, again, you decrease absorption of these nutrients, increased turnover and metabolism. There's an increased requirement because of the energy expenditure in that sort of hypercatabolic state and stress state. And then you have the simultaneous increased need for tissue repair. So your risk of injury goes up in this state. And marginal deficiency states. So if you're a little bit deficient, let's say glycine and proline are on the low end of normal, and maybe you're kind of marginally deficient in B6 and folic acid and B12 and B2. So your homocysteine level is a little high. You're not methylating well, but homocysteine interferes with cross-linking of collagen, and I don't have the proteins that I need for cross-linking collagen anyway. My risk for injury is significantly elevated, and that really may not be an issue until I'm in this high state of stress. So if I'm marginally deficient, I get through training camp, no problem, and mid-season happens, I'm kind of into the grind of the season, and I have a tendon rupture, and everybody's surprised. Why did this happen? What did we miss? And this is why I think, testing or looking at this and making sure that you're tracking their nutritional state regularly is important. You can't wait till something happens and then try to reel it back in. So neurochemically, this is kind of a quick synopsis or overview of the main chemicals in the brain that drive one of the two sides, the sympathetic, which is fight or flight, or parasympathetic, which is rest and relax side. And you start with dopamine, and dopamine, the two amino acids that will become dopamine are your phenylalanine and tyrosine. And it requires B6 and iron and folic acid as cofactors for driving this manufacture. So you form dopamine that helps with drive and motivation. And then in a stress state, that becomes norepinephrine and adrenaline. So you're more alert, more vigilant, you get increased cardiac output, better circulation, you increase circulation to the muscle and to the brain so you can think and move fast, but you'll decrease circulation to the gut. The other chemical that is important to discuss is glutamate, which is actually your main excitatory neurotransmitter in the brain. So this is your gas pedal. So glutamate goes up, and that helps with memory and learning. But in a normal state, what will happen is your body will break down adrenaline, and the cofactors for that reaction I'll talk to you about in a minute are important, but copper and magnesium and S-adenomethionine, these are things you need to break down adrenaline and also to convert your happy chemical serotonin into melatonin. So a deficiency state in any of those may make it difficult for you to get into a sleep state. And glutamate has to convert into GABA. So GABA is the main calming chemical in the brain, and it helps with sleep, initiation of sleep, and it helps with repair in the brain. And you require B6 and magnesium for that, and another amino acid called taurine. And we'll go through some of this here. So if you look off to the left, just talking about what happens with glutamate converting into GABA. Glutamine is the amino acid that becomes glutamate, and then glutamate converts into GABA, and B6 is the main driver, but you need magnesium for this as well. One of the things that's interesting is if you are talking about things like concussion, glutamate is one of the key central figures that plays a role in what's happening with what we call neurotoxicity after a brain injury or after a concussion. So glutamate is this excitatory neurotransmitter, and production ramps up. And you need something called cysteine or N-acetylcysteine to help convert glutamate into a protective chemical compound called glutathione, which is how you get rid of oxidative stress in your brain and in your liver and your body everywhere, basically. But that's glutathione is your main antioxidant that you produce. So it's not just GABA that is important in this, in these pathways, but it's also glutathione that helps with calming the brain. And glutamate's a central figure. If I look at what's happening with catecholamines, you'll see this BH4 here between phenylalanine and tyrosine, and between tyrosine and DOPA, and then B6 as a cofactor. And then for dopamine becoming adrenaline, copper, and vitamin C. And in breaking down both of these structures, copper, vitamin B2, magnesium, S-adenomethionine, so we have all these cofactors which are supposed to be present. But in a stress state, if your absorption is not great, or if you have an issue genetically with, using methylfolic acid, then it affects what happens with S-adenomethionine, and that prevents your breakdown of adrenaline. And so you can spiral out of control fairly quickly with a marginal deficiency state.
Dave, can I ask you a question real quick?
Yeah, absolutely.
The N-acetylcysteine story, can you
Yeah.
say that one again?
Yeah, so one of the first things that happens after a concussion is you get what's called glutamate excitotoxicity. So glutamate is a neurotransmitter. Your immune cells dump it. So they release it because it can convert back into glutamine, which is a secondary fuel. So that's part of it. But it also ramps up ATP production. And glutamate, in order to convert that into GABA, you need B6 and magnesium, but to convert it into glutathione, you need cysteine as a amino acid. So if somebody who's cysteine deficient or doesn't have N-acetylcysteine, which is something that we use sometimes to help with concussive exposure, if you don't have that, you can't create glutathione, and so your recovery actually from a concussion is probably much slower.
So from a nutritional perspective, if you're going to do a blood panel on somebody and you don't have unlimited resources, like what are the top 5 or top 10 that you would want to have tested in somebody that you suspect has one of these overtraining or high stress or concussive type injuries?
I would tell you the things that I consistently will request. I want a homocysteine level on a nutrition panel, and homocysteine, in part, it's driven up if you have an MTHFR deficiency, so genetically you have a hard time methylating, but also in deficiency states and people who take medications for reflux, as an example. They don't absorb B vitamins and homocysteine level climbs. People who drink alcohol regularly. So in your athlete crowd, it's the partiers. They have their vodka or Hennessy or whatever at night, every night, when they go out, and they are depleting B2 and B12 and methylfolic acid and B6. So they end up in deficiency states, and that homocysteine can kind of capture that for you. So that's a really important one. And then I always want to look at magnesium, particularly the intracellular magnesium, because that's where magnesium kind of resides. You lose most of your intracellular magnesium before your serum magnesium ever changes. Your bone will dump magnesium to keep serum magnesium level in a normal range. So you'll lose intracellular magnesium production, which affects metabolism long before your serum levels change. So you need an RBC magnesium, and you should be kind of in the mid-normal range, maybe in the upper mid-normal typically. So those would be 2 biggies. I guess I look at a cortisol DHEA and look at that ratio. That helps. Vitamin D, because that affects so many different aspects of metabolism and bone density and mood. If you can get an amino acid profile, and most labs are starting to do, even Quest is starting to do this. And Quest will be sort of the dominant lab of because of their marketing, what everybody ends up using in their nutrition panels, although they aren't very good, unfortunately, at least yet. But at least they do have the amino acid testing, and I think that's really helpful. I think it's helpful to get C-reactive protein to look at inflammation, because that'll affect what happens with manufacture of neurotransmitters, and it tells you about gut function. And another marker I like to look at is lipid peroxide. So I want to know oxidative stress and inflammation. That's kind of what leads to the hormone shifts that happen with overtraining. So if I can get those in a panel, it's a huge help to know what's going on internally.
That's great. Thank you.
Yeah. And by the way, if you want to increase cysteine in the diet and raise glutathione, whey protein helps. It's pretty high in cysteine. So, just kind of showing you guys, this is simplified, but you can see how many cofactors are necessary for all this stuff to work properly. And a marginal deficiency state can affect significantly what's happening with mood. If I'm B6 deficient, or marginally in a marginal B6 state, or I don't methylate well, it's really hard for me to sleep. Sleep will affect my recovery. And I mentioned here what happens with tetrahydrobiopterin. So that BH4 that was listed with in most of these pathways. So you see tryptophan to 5-HTP requires tetrahydrobiopterin or BH4. Phenylalanine to tyrosine, tyrosine to dopamine, and BH4 is important there. So what is tetrahydrobiopterin? Well, it's an enzyme that causes the conversion of all of these pathways. So tryptophan, dopamine production requires it, but also the conversion of arginine to nitric oxide. So vascular dilation and health requires normal tetrahydrobiopterin, which in tetrahydrobiopterin, you need to be able to methylate. So methylfolic acid, S-adenylmethionine, folic acid, those are all things that are important, and it's inhibited by inflammation and oxidative stress. So depression, there are significant links with depression and hormones, but also with inflammation and oxidative stress. It impairs these enzymes from working properly, and then brain function doesn't happen. So your athlete starts to have depression and lack of motivation and drive. And if you have an athlete that's in that state, you want to kind of try to back them away. You want to do things that help them with mitigating stress. So that could be, using float tanks, using a sensory deprivation therapy, doing, infrared saunas. We sometimes do that with the military community. We're looking at that or studying those things as helpful. Nutrition is huge. Your protein needs go up significantly when you're in this state, and then backing off of training a little bit. It's not an issue where you can just push through and everything will be fine. We used to do that to athletes, but then we see all these athletes and wonder why. We've got NBA players who are 50 years old and have a sudden cardiac arrest, and NFL football players. Why do offensive linemen have an average lifespan of 55 years? So inflammation and oxidative stress play a role in TBI recovery and cardiovascular disease and all of these things. But it will affect, kind of getting back to the brain stuff, it affects what happens with neurotransmitters. And this link here, if you see what happens with gut and brain, let me actually go to this one. It's a little bit better slide. You alter how your mood is when you have inflammation. So you see this increased brain IDO or indolamine that is stimulated by inflammation. So it changes what happens with tryptophan. So tryptophan, instead of becoming serotonin, which makes you happy, and then becoming melatonin to help you sleep, it goes down an alternate pathway, which is the kynurenine pathway. And kynurenic acid interferes with the neurotransmitter we were talking about earlier, which is glutamate. So glutaminergic synapses, NMDA receptors, this is communication within the brain. Kynurenic acid interferes with it, so people get brain fog. So after concussion, what's one of the main symptoms of it? Foggy brain, which is driven by inflammation and this chemical kynurenic acid. And kynurenic acid will convert then into quinolinic acid, and quinolinic acid is really toxic for the brain, and it activates NMDA receptors, and it has a high association with suicide. So it's something that we're looking at for the military community. And if you look at, CTE, and you see some of these guys, like Junior Seau is a example of a linebacker that shot himself in the chest. He knew something was wrong with his brain and was severely depressed and probably impulsive. And, with all the tackling he did, I'm quite sure he probably had some neurochemical shifts that are along these lines, but this also affects what happens in the gut and how you digest food. So this article here, just basically lists this, that 80% of competitive athletes have significant levels of depression at some point in time. And it's linked with all the things that we've talked about. I'm gonna skip through some of these slides because it's, maybe not as pertinent to what you guys might look at or test for, but prolactin is a hormone in the brain. This would be another thing maybe to look at on an endocrine panel, but prolactin affects all of the other hormones, and prolactin is produced by the pituitary gland when dopamine production falls, which will happen in a chronic stress state. Then prolactin tends to climb, and when prolactin climbs, then everything else begins to fall. So you're looking for a prolactin level, ideally probably less than 7.5. I accept 10 or less on a lab panel, but if your prolactin level on an athlete is 15, which is normal, it doesn't mean that they're normal. It means that they're in a stressed state and their endocrine system is beginning to struggle. And this is just an old study that kind of showed what happened with testosterone. And you can see as prolactin levels went up, testosterone dropped. And it took them a while to recompensate and kind of regroup, which was, about at the 2-month point. And I see this a lot. Preseason, if I check a prolactin level with an athlete, their prolactin level is going to be on the higher side and their testosterone level begins to drop. And this slide, I would, encourage you to kind of know kind of the basics, at least, of what happens with cholesterol metabolism when you're looking at a lipid panel in an athlete. Don't look at it from sort of the marketing standpoint of what statin medication, drug companies have convinced everybody that they need to look at. And cholesterol is a problem, and you need to be on, a cholesterol medication to fix this disease. Well, why is your cholesterol up? Well, you're having an issue somewhere in this tree. If you're an athlete, it could be genetic. There's small percent of the population that has high cholesterol because of genetics, but genetics and diet and stress are all players. But your big one in athletes is going to be your stress response. Cortisol production is ramped up, so your liver's making more cholesterol. You got gut permeability, so you're absorbing more cholesterol out of the gut. Something is happening with your athlete that is driving your cholesterol levels up, and that's a clue to you that something is off. And I think this is a great model to look at endocrine dysfunction and what happens to people with endocrine dysfunction. It has to do with energy deficiency. So your energy deficiency state can happen because you've had a concussive injury, and inflammation and oxidative stress begin to change what happens in the brain and the body. You can have it because you're not eating enough, and that's really common with athletes. They, especially, basketball players that want to maintain weight or want to stay light on their feet, they eat and they're picky with what they eat, but they don't eat much. And what they eat might be, calorie dense and one time a day and very nutrient depleted. And that's how they kind of grew up. I have my McDonald's in the morning, and then I'm going to have, something after lunch. I'm going to have biscuits and, Popeye's chicken or something after lunch. Well, you're for sure going to end up with some sort of an issue with endocrine dysfunction and nutrient deficiency state in somebody that has this sort of eating pattern. So you guys can fix that. But you can see what kind of happens as a gradual progression in these energy deficiency states, whether it's because, again, stress or inflammation is present, or it's just macronutrient wise, these guys aren't taking in enough. They don't want to, eat. Let's say they switch over to a vegan diet and they're expending 4,000 calories a day. How do you get enough calories in that state? It's really difficult. So it's something for you to obviously to monitor. And this is a complicated sort of slide in the picture, but it describes some of the things that we've been discussing. It's your change in your metabolism, and that affects bone density. It affects what happens with testosterone, cortisol, and immune function begins to change. So this is a big spider web that gets thrown out of balance when you're in an energy deficiency state. And to kind of bring in some of the specifics. So if I look at thyroid, what happens with thyroid? We mentioned that thyroid controls how many of the mitochondria that you can produce. So energy production in the body and in the brain. Your brain, your hypothalamus signals the pituitary. The pituitary releases thyroid stimulating hormone, or TSH. Your thyroid then releases something called T4, which T4 is tyrosine and 4-iodine molecules. So tyrosine is something we mentioned before with dopamine, but it's involved with dopamine manufacture, but it's also part of thyroid hormone. So in that chronic stress state where you're constantly pumping adrenaline, you can have sort of a depletion of your tyrosine pool, and you'll see thyroid get thrown off. But thyroid can also be thrown off by cortisol. Cortisol will suppress TSH production for the brain. So if you just check TSH, you're not checking full thyroid function, and it's not adequate to know what their thyroid function is. So TSH might be completely normal. Normal is between 0.4 and 2.4, and let's say they're at 2. Does that mean thyroid function is enough? No, not if their cortisol is really high. So T4 release may be low normal, and then their conversion into the active form of thyroid is basically pulling the pin on the grenade. You pull one of the iodine molecules off and you activate it, you get T3, and then that tells the cell what to do. And with high cortisol, that is suppressed, or you convert it into something called reverse T3, which kind of slows your metabolism down. So stress state affects metabolism, it affects nutrient absorption, it affects your neurochemicals. I mean, kind of seeing a pattern of, gradual breakdown and destruction that happens. And here's a little, article just looking at thyroid hormone, particularly the active form, which is T3. And again, it's probably hard to get somebody in medicine to check T3. It's almost taboo. If you ask for TSH and T4, sure, we'll do that. What about a T3? Well, we don't check that. Why not? It's part of how thyroid function works. And so when you're dealing with somebody who's in a high performance setting, you really have to look at what happens with T3. T3 affects VO2 max. Your free T3 and total T3 levels will begin to fall in a stress state. And I see this with the military guys. Their TSH looks great. Their free T4 looks great. So they're releasing enough from the thyroid hormone, and then total T3 or free T3 is low normal. And what do they complain of? Well, I've got cold hands and cold feet, and I'm a little constipated, and I kind of have brain fog. So beyond just the serotonin pathways or tryptophan that we talked about converting into chynurenic acid, you can have thyroid dysfunction that plays a role in this. So T3 is significantly important for mitochondrial function and energy production. And if we mention macronutrient deficiencies and energy production state being an issue, so you don't have enough ATP to run the engine, thyroid also plays a role. So if you don't have enough mitochondria to keep up with energy demand, same thing. You end up with an issue with brain fog. Thyroid also affects cardiac output and stroke volume. So a patient that has low thyroid function is going to have fatigue from a vascular standpoint or cardiovascular standpoint, but also from a cognitive standpoint. And this is just, this is kind of a quick summary article that discusses this. What do thyroid hormones do? Well, they affect mitochondria, and it affects what happens with oxidative stress. And oxidative stress activates your immune system. So if thyroid function is off after a concussion, then recovery is slower. So it's something that you have to look at after a concussion.
Dave, in your experience with military or professional sports, how often do you see a normal TSH, normal T4, and abnormal T3? Is it as high as that 90% that article showed?
Probably. Yeah. And what you see is not what we would say in the medical community is it's not the lab abnormal. So, when we pick lab normals, we're kind of going, okay, here's the top 5 to 10%. Those have to be abnormal because it's out of that bell curve. And here's your bottom 5 or 10%, and that's out of the bell curve. But what if let's say, on a free T3, if the normal level is 2.4 to 4.2 in most labs, and let's say I've been running 3.5. So my free T3 is great, and I drop down to 2.4. Am I normal or am I not normal? Well, I've got cold hands and cold feet. I'm having hair loss. I'm constipated. I've got brain fog. My metabolism is slowing and I'm gaining weight. So I may have all the symptoms of hypothyroidism, with a normal TSH and T4 and quote normal free T3, I'm not normal. I'm in, you know, what you would describe as hypothyroid symptoms. So this is where it kind of gets tricky. When do you step in and do something? But you can support this nutritionally as well. So I would say
reverse T3 in that scenario.
Oh, I love to look at reverse T3. And if you have a normal level is usually between, I want to say it's 8 and 20 or 8 and 24, somewhere in that range. Depends on the lab. But I want to see somebody under 15. I want to see 15 or less on their reverse T3. And somebody who's running 19 or 20 is in a stress state. Now, if their free T3 is okay, I may say, I'm not going to do anything, but.
And that T3 is just converted to reverse T3, which is not usable, correct?
Yep, exactly. And it would be a protective mechanism. If you were a farmer 4,000 or 5,000 years ago and your crops burned down, you don't want a really fast metabolism. You want to get to your next food supply before you basically run out of internal fuel and digest yourself and die. So your metabolism slows way down, and that's why cortisol has this huge effect on thyroid. So it's a survival mechanism, but we don't have shortages of food. So in a stress state in an athlete or a special operations operator, you know, these guys are in a stress state and they're having thyroid dysfunction issues, which are related to stress, without necessarily having grossly abnormal labs. They're just, you know, probably normal TSH and very low normal free T3.
How do you fix it? Like, it's confusing, right? Because you see all these issues, and then if it's a doc who's not you, you're being told you're normal,
right?
And then what do? Is it, you say get more sleep? Okay, so try to reduce stress in your life. All right, but then you've got a big game, and if it's a college athlete, they've got final exams and
right,
and a girlfriend problems, and there's all this other stress. So what do you do?
Yeah. So, you know, a couple of things that help drive the conversion of T4 to T3. One of the big things that helps is selenium. So, and that helps with glutathione production. So if you can, you know, 2 to 4, probably 4 Brazil nuts a day, give you 200 micrograms of selenium. That's helpful. You can supplement with selenium. I recommend doing that. I think when somebody is in that state where you start to see that thyroid conversion issue, that's one of those areas where I would probably step in and say, okay, I want to obviously I want a fixed diet. I want to help with sleep. I want stress mitigation. So, you know, go find a quiet place and just do relaxation, you know, get a Headspace app and do some meditation, or go do prayer, or do something that helps your brain unplug. Sensory deprivation, whatever it is that maybe helps that person. But then I want to do things that help support the conversion. So I want them to have more B12. I want them to have more selenium. I may even look at some of the adaptogens, and there are some supplement companies that are NSF that have things like ashwagandha, which has downward pressure on cortisol release and helps with the conversion of T4 to T3. So those would be circumstances where I might use nutraceuticals to kind of help support this person through this period of time where they're super stressed.
Great, thank you.
Yeah, and unfortunately, I'll kind of just tell you guys, when you're out and kind of getting into the sports community, I mean, it has to be some sort of, there's so much garbage that exists in the supplement world, which is why it has such a bad connotation. You know, supplementing is, you know, it's kind of another thing that's kind of taboo. Why would you give them that? You're just peeing your money away, right? But a lot of it has to do with the quality of what you're giving people. And there are companies that go through quality testing, and those companies go through GMP certification and NSF certification. And there's NSF Sport that you're seeing all these professional organizations are kind of moving towards having a certification like that, so that they can test, you know, hey, there's no banned substances in them, which is good, but it does limit what you have available sometimes for the professional athletes. There are really good things that might help in this situation that might not be available for that athlete because they're not NSF Sport. But I think that will grow or continue to grow over the next few years. And I think eventually what you'll see is, you know, pretty good options for supplementation for people that are helpful for these type of situations beyond the, you know, kind of really narrow window of things that we have that are NSF Sport right now. DHEA, we've kind of talked about this a few times. I just want to kind of mention, when you're talking about athletes that are overtraining, you see osteoporosis that's common. When you think of gymnasts and long distance runners and women, but we kind of pretend like guys don't get, these issues as well. And absolutely they do. DHEA is one of the factors that plays into this, that has an effect on bone density, has an effect on cytokine release. So interleukin 6 is one of the major cytokines that's pro-inflammatory, and interleukin 6 has a role in what happens with serotonin production in the brain. So it affects, cognitive function and mood. It affects what happens with your short-term memory center. So the BDNF, or brain-derived neurotrophic factor for healing, it's important to have DHEA. So if you've got a stressed athlete with a really poor diet, and let's say that inflammatory markers are high, and they're a pizza and McDonald's eater all the time. That's what they do because they're an offensive lineman, and they're trying to maintain their 350 pounds of weight. What would you expect to happen in somebody that has a minor concussive exposure as far as recovery? They don't have the sort of the baseline that helps them with recovery, and their recovery is probably going to be slower, and then their outcomes are usually worse. Testosterone is significantly impaired in stress. This is obviously the big anabolic hormone that everybody talks about with athletes. What's your testosterone level? I mean, athletes on their own will go test their testosterone, even when you don't or you can't because of rules. They'll go check it on their own. They want to know what their testosterone is, just because it's a good feedback tool. If your preseason, your testosterone is 1,000, the high end of normal, and mid-season you're at 400, they're probably symptomatic and they're in a breakdown state. It doesn't mean, hey, it's okay to replace it. It just means something's off and I've got to do something interventionally to help this guy. And this was just a study that was in, for Ranger school, where they put him in a calorie deficit and had him do heavy training, and, huge surprise. They lost explosive power, and body mass was lost, and their repair hormones were significantly altered, even though cortisol went up. With training, testosterone typically can drop for a couple of days, particularly with a heavy training session. So this is more feedback on rest and recovery days. So if you've got somebody where everything looks low, if you want to kind of back them away. So we look at mileage, on ice or on the basketball court with guys. I mean, how much running are they doing? How heavy are they training? What are their loads? A guy that plays, 38 minutes in a basketball game, probably is not a good idea for them to have a 3-hour really intense practice the next day and then expect them that, somehow they're magically going to be on top of their game in the following day when they play on the road after a, time change or time zone change game. It's just, you're going to see an up and down performance from an athlete. And that's where we step in and mitigate and say, hey, you know what? Hey, coach, if you got a good coach that listens, hey, coach, this guy played a lot of minutes. We're seeing shifts in them hormonally. If you can look at some of these, if testing is allowed for you or you have the opportunity to, why don't we back off on this guy a little bit? Let him do a light practice and some shooting, and let him recover a little bit so that he's ready for the next game. The coaches are about winning, and sometimes they need to know that their chances of winning are much less when their athletes are all in this catabolic breakdown state. And this is a quick slide on free testosterone, that your free T drops, and then that's what really causes the mood change. Impaired sleep impairs testosterone production. I know I'm blazing through some of this, but I just kind of want to get to some other areas. PTSD, it's an inflammatory problem, and testosterone and cortisol ratios play a role in somebody, whether they're at risk for PTSD or not. Testosterone is linked with inflammation and mitochondrial function. So again, we have other hormones that are linked with energy production. And I'm going to skip forward a little bit because I want to get to a slide. This slide, this is a great summary that was, I think, in the Journal of Clinical Nutrition, that kind of discusses what is happening with a concussion and inflammation. So you have this concussive injury, whether it's, a football injury, it's, an elbow to the head going up for a rebound in basketball. But blast wave exposure in these guys from breaching, in the military community, you get activation of microglia, the immune cells, and you get axonal damage. And the axonal damage causes a disruption of membranes. And so we discussed a little bit about glutamate release, that excitatory neurotransmitter, and its effect on NMDA receptors. So NMDA receptor activation happens, and calcium gets sucked into the cell, potassium gets pushed out, they deplete magnesium, and they end up with mitochondrial dysfunction. So their energy producing ability is gradually lost, and they end up in this state of hypometabolic function. So they can't produce enough energy to keep up, and their oxidative stress levels are high, and so they're at really high risk for repeat injury. And this is where it kind of comes in, where I like to test lipid peroxidation or lipid peroxide. So if reactive oxygen species are high and they're in this poor metabolic function state, the risk of having cellular damage is really high. So the risk of cell death is high. We discussed a little bit about kynurenic acid and quinolinic acid affecting NMDA receptor function. And if they, before they ever get to this, if they're magnesium deficient, they can't get rid of quinolinic acid. So they may have primed NMDA receptors, and a minor injury causes a huge problem for them. Somebody with a poor diet that has let's say their diet is sort of, Big Macs and Snicker bars. So they got all these calories that come in, but they have no way to process all of the calories that come in. They have increased oxidative stress already. Then you add an injury to it, you're talking about having a second impact syndrome before they ever had their first impact. So they're already in a compromised state, and inflammation and microglial activation might already be present before they've had a concussion. So what you do on the front end with them nutritionally saves these guys in the long run. And it's hard to get them to understand that at first, because a lot of them, again, they're in that suboptimal sort of, existence where they say, I feel fine. I don't know what you're talking about where I need to change my diet. I feel fine. I've always eaten this way. But if you can break this down into an understandable level for them, then they start to look and like, oh, got it. I don't want to have the CTE issues later on in life, or I don't want to have, Alzheimer's disease or Parkinson's or whatever the neurodegenerative disease might end up being for me as a result of this chronic inflammatory state and oxidative stress. And I want to point out a couple of articles to you, one on TBI and concussion and neuroendocrine dysfunction, that if you have oxidative stress and inflammation that this slide shows, there's a third phase of a concussion. So primary injury is the bruising, contra coaxonal shearing. Those are the things that happen. Secondary injury is oxidative stress and inflammation, which is on this slide. And then you can get decreased blood flow. But there's a third phase of a concussion, which is not mentioned in a textbook anywhere. You're not going to find it, but at some point, somebody will realize that this is part of it. And you can see, in a mild TBI, it's almost 40% of them that have neuroendocrine problems. It's really common. So this is just tackling sort of typical TBI or concussion, a car accident, whatever it is. This is a picture of a blast wave coming through this guy. One of these guys is a friend of mine. So he's firing a shoulder rocket, or a Carl Gustav rocket, and the blast wave comes through, and on a video you can see the dust picking up behind that yellow line. That yellow line is not overexposure, it's the blast wave coming through, and that causes a concussive injury. And the same thing that we see in a regular concussion, you'll see in a blast wave, which is the pathophysiology in the brain, or where the damage happens is a little different, but it's very similar in percentages. About 42% of those people that are exposed to a blast concussion will have neuroendocrine problems. And it's in the military, unfortunately, it's kind of taboo to test this. The people that push for testing the most that I see in the military are the nutritionists, because they're working with these guys and see them up close. The human performance department looks and pushes for testing, and medicine has been slow to catch on that this is part of the problem that they see with these guys with depression and kind of gradual kind of deterioration in function and performance. It's related to neuroendocrine problems. Growth hormone, I won't dive into that one too much. I just want to look at a couple other slides with you guys. PTSD and inflammation. There's significant links with inflammation and PTSD. It's not surprising. It's linked also with neuroendocrine dysfunction. There's a reason why people get PTSD, and it's not just, a meteor fell out of the sky and then I had PTSD, and it's beyond just mood. So my mood might change and my inflammation might change because of, this chronic stress state, but it's still linked with inflammation and oxidative stress. And concussion and inflammation, same thing. You see the links with inflammation and concussion. And one thing that I want you to be aware of is we discuss inflammation and oxidative stress. If you have somebody with high lipid peroxides or high, let's say, if you do a really advanced panel, like the Genova Cardio-Ion is a great nutritional panel that I like to look at, that looks at 3 oxidative stress markers. If they're all high and I've got an athlete, I want them on some sort of antioxidants, not necessarily around their workouts, but maybe at nighttime. Maybe they're low in or they need some cysteine, N-acetylcysteine, something that we discussed that might help with glutathione production, or put them on glutathione. But I would intervene when somebody has high oxidative stress markers, but if they don't, I don't want to touch them. I don't want to impair their recovery and normal sort of adaptation mechanisms that they would have from training. And understanding inflammation on the other side, this is a two-sided pathway. We used to think of inflammation as a standalone, that you get inflammation, you convert omega-6 fats into arachidonic acid, which is on this slide. Arachidonic acid then converts into prostaglandins that causes pain and redness and swelling, and you get neutrophil infiltration. And so if you can block that by taking Mobic or Motrin or ibuprofen or Celebrex or whatever the COX-2 inhibitor is, then you blocked inflammation and you help them heal. And that's not the case. You are preventing them from healing because you have to have resolution. It's another side of the pathway. If you don't convert omega-3 fats through the exact same enzymes, COX and LOX, if you don't convert them into resolvins, protectins, and maressins, you will not heal. You get organ fibrosis and delayed wound healing and chronic inflammatory state, which is what you see in people who have CTE or Alzheimer's disease. So when you put people on omega-3s, or if you look at an omega-3 or 6:3 ratio, which is another great test to do, by the way, either arachidonic acid to EPA ratio or look at an omega-6:3 ratio, you want these guys fairly balanced. Typical guy you'll see is a ratio of 30:1, which is not helpful for healing. You want them, maybe 10:1, somewhere around that ratio. But in people after an injury, you have to be aware that they may not be able to, even if their diet is great, they may not be able to produce enough pro-resolution mediators on their own, and you may have to help them with that, either by supplementing with SPMs, and there's some that are available now for people, or if you've got somebody that's not in a sport or whatever that may cause bleeding. So if, let's say, somebody is kind of a couch potato, but you're working with them on nutrition, and they're not healing from, let's say, an Achilles tendonitis that they have, like I've seen this, let's say, in an admiral who's obviously not, a professional athlete, but they've got Achilles tendonitis. What would I do if I'm giving them fish oil? The only thing that helps as far as a non-steroidal is actually aspirin, because it irreversibly acetylates COX, causes an alternate pathway to be activated, and then produces SPM. So you either have to put them on SPMs, or you have to put them on a baby dose of aspirin a couple of times a week to help with SPM production, and get them into that healing state. Because that's really what omega-3s do, is they are converted into these active forms, and that's where all of the healing and protection happens, is because of this productive pro-resolution pathway. When somebody is in a state of chronic stress or chronic inflammation, and their DHEA is low and testosterone is low and cortisol is high, it impairs this conversion of EPA DHA into pro-resolution mediators. In women, it's estrogen. As women age and they hit menopause, they lose the ability to produce pro-resolution mediators. So these are things in where for me, I kind of step in and say, okay, I've got a guy who, first thing we address is their diet. I don't want them to have this huge omega-6:3 ratio. We're getting the guy to eat some fish regularly. Maybe they're taking an omega-3 supplement. but this guy is starting to break down. They're having some joint discomfort problems when they're playing, or they're having a little tendon dysfunction. That's where I typically will step in and say, okay, we got to go beyond omega-3s and start intervening with pro-resolution mediators. So in kind of, summarizing in how I would intervene with people, I want to know pathophysiologically the model of how things work, which is this: oxidative stress and inflammation. And then I want to know, from the athlete, how much inflammation does this guy have? Somebody who is, let's say, European soccer model. They play once a week. I mean, I'm not discounting that they are, they're very highly trained athletes, but I don't think they have the same issues with this chronic inflammatory state that we see in, let's say, an NBA player who plays back-to-back games. They might have 3 or 4 games in a week. They're practicing every day. They might get 3 days off in an entire season. So they're stuck in an inflammatory state. So I want to know that state of that person, and I want to know, nutritionally where they are. And then if I can get some clues about what's happening with, let's say lipid peroxides or oxidative stress, and I can look at an omega-6 to 3 ratio and kind of have an idea, okay, is this guy likely to produce some pro-resolution mediators over time if I'm supplementing omega-3s? If they're in an inflammatory state and have high oxidative stress, then I have to be more aggressive with what I do with supplementing while I'm trying to fix their inputs. How do I get them rest days? How can I communicate that with the coach? Hey, we got to back off on this guy because he's starting to break down, and we're seeing some indications that he's in a catabolic state. So that's kind of my approach.
Would that be would the SPM like supercharge then be that baby aspirin step, or would there be, or would it be a combination of perhaps that occasionally plus the omega-3s plus the rest days?
I kind of do all. I mean, if I, with the guys that I have that I work with on the professional level, they're all in an inflammatory state. I mean, I can, look at their labs. It's, like 90% of them, we talked about thyroid function, test kind of showing some abnormalities. It's going to be the same by the end of the season. And what I end up doing is preseason, they're on omega-3s. As the season starts, I add SPMs to the regimen, maybe 1 gram of SPMs, and they're taking 1 gram of omega-3s. And then towards the end of the season, I'm not so worried about the omega-3s and other than in their diet. And I kind of will look at the guys that are kind of broken down, and I might ramp up a little bit on their SPM. So maybe I go up to 2 grams a day of the SPMs.
So what is it? I'm not familiar with an SPM. Like, how do you, is it a supplement?
It is. Yep. They look like little baby fish oil.
So heavy, but it's an oil. It's a omega-3.
Yeah. It's an omega-3. Yeah. So there's a couple of companies that, well, there's one company that manufactures it, which is over in Spain, but there's a couple of companies that distribute them. And in the sports world, the only option is something called ProResolve. And that stuff is, I've been using it, oh gosh, probably 4 years or so with athletes. The first time we used it was with I got samples and we used it with the Capitals when they first came out. And we had a mutiny when we ran out of samples right before that finals matchup with the Vegas Knights. So we didn't have them for the first game, and guys were upset because they noticed a huge difference in how they feel. And we got another box of samples, and then guys went back on them, and then everybody was happy. So whether that was sort of so a little bit of placebo in their head that they freaked out when they didn't have them, but I mean, the feedback consistently is really good with those, particularly for these guys in a chronic inflammatory state.
The idea is you're bypassing all these different biological steps and just giving SPM, which is heavy dose fish oil. Is that what it is?
It's an omega-3 that's activated. So instead of waiting for the body to do this process of converting them, which can take months. So if I take high dose fish oil, and we'll see this in somebody who had a myocardial infarction, if you test omega-3 levels and then you test SPM levels in these people, they might have normal omega-3s, but they have no SPMs. And so putting them on high dose fish oil will gradually drive SPM production, but it might take them 3 to 6 months. because they're in a chronic inflammatory state. It slows this conversion process down. It's really slow. Just like if you took, flaxseed oil, how much flaxseed oil do you need to be able to drive DHA production? On some people, they never get there because it's slow. It's just not efficient, but you can theoretically do that. So when I'm working with an athlete, if somebody is in great shape and their diet is good and they're, no complaints and they have rest days and they're really on top of this stuff, I just make sure they're getting, salmon or pompano, or they're getting some good high dense omega-3 fatty acid type fish regularly in the diet, and then measure an omega-6 to 3 ratio. And if they're, 5 to 10 to 1, great, no problem. If they're maybe 20 to 1, all right, let's put you on an omega-3. But guys that don't have rest days and they're, starting to have some joint issues or kind of breaking down gradually, or if I test, let's say their free testosterone level is low or low normal, that's an example where I'll say, okay, that probably indicates they're in a chronic inflammatory state or an oxidative stress state, even if that's all that I have. And why not put them on pro-resolution mediators? I just put them on pro-resolve. There's another company, Metagenics, that does them for, for practitioners to dispense. That's what I have in my office, but in the pro athletes, I use pro-resolve. I'll just put them on those and then try to work on lifestyle and nutrition and relative rest days to kind of back them away from the ledge, where they're breaking down. Does that make sense?
Yeah, it definitely does. I appreciate that. Unfortunately, we are out of time, but I'd love, and some of the students probably have to run to a different class, but does anyone have like a burning question we can ask them real quick before we need to give up the room? Yeah, some of them want to email some questions that I might forward on. And then if possible, some version of your talk would be wonderful to get those references and things if they want to look back at something. Would be much appreciated. Let's give Dr. LeMay a round of applause. And
good to see everybody.
We appreciate your time today. Thank you very much.
Yeah, you're welcome.
All right, I'll be in touch. Thanks so much, David.
All right, Mike. Thank you. Bye-bye.